Raised intracranial pressure cerebral blood flow brain edema. Dr. Samir H. Aboud. The intracranial cavity. The contents of the intracranial cavity. 1. The brain about 1,400 milliliters. 2. The blood 75 to 100 milliliters. 3. The CSF 75 to 100 milliliters. All these three compartments are essentially non-compressible, and any change in the volume of the brain causes a reciprocal change in the volume of one or both of the other two compartments. This is called the Monroe-Kelly doctrine. CSF obstruction to the flow of CSF at any point results in dilatation of the ventricular system, proximal to the obstruction with profound effect on intracranial pressure. Indications for access and contraindications. CSF analysis, bacteriological, immunological, cytology. 2. Measuring CSF pressure in cases of pseudotumor cerebri, and normal pressure hydrocephalus. 3. The administration of antimicrobial and antineoplastic agents, normally excluded by the BBB. 4. Therapeutic CSF drainage, in cases of CSF fistula, pseudotumor cerebri or communicating hydrocephalus. Methods of access contraindications. Lumbar puncture local env. 2. Cisternal puncture, ICP, due to Sol. 3. Ventricular puncture, blood dyscrasias. Anticoagulant therapy, CBF-BV equals 75 milliliters I.C.VP equals ICP CBF, 50 milliliters / 100 grams per minute CPP equals CREP-VP ICP. CBF equals CPP / CBR? CREP, VP, ICP. CBF equals CBR? Cerebral autoregulation. Brain volume SOL edema, increase in brain water. An increase in brain volume is produced either by a SOL edema, increase in brain water. 1. Vasogenic edema, extracellular, disturbance of BBB. Localized around tumors, abscesses, hemorrhages and localized cerebral contusions. It may lead to herniation. 2. Cytotoxic edema, intracellular, hypoxia, cardiac arrest, intoxication, severe hypothermia. It is usually generalized. 3. Osmotic edema, ECF, abnormal 80H2 severe hemodialysis, or excessive ingestion of water, hysterical. 4. Hydrostatic edema, ECF due to acute hypertension. Elastance and compliance. Compliance is that quality of distensibility available within the intracranial contents, which enable them to adapt to an expanding IC lesion. Elastance is the resistance offered by the intracranial contents to the expansion of an intracranial mass. It is the inverse of compliance. Compliance is decreased by increased by 1. Hypercarbia, hypocarbia. 2. Hypoxia, hyperoxia, PAO2 greater than 1000 mm Hg. 3. Sleep, hypothermia. 4. Anesthesia, barbiturates, intracranial pressure measurement. Normal ICP, this is 50 to 200 mm. Water, 10 mm Hg, it is pulsatil owing mainly to IC arterial pulsation. It also shows fluctuations reflecting the respiratory and cardiac cycles. Measurement. 1. L.P. With the patient on his side, the LP needle is connected to a manometer. This method is not accurate, cannot be used for monitoring and can be dangerous. 2. Ventricular cannulation, it is more accurate, can be used for long periods, but may be complicated by infection. 3. Subdural sensor, these are the safest and most reliable, and 4. Extradural sensor and are usually used for monitoring. Effects of increased ICP. A. Effects on vital signs. These appear to be due to compression and distortion of the brainstem. These effects are noticed in patients with critically raised intracranial pressure, and in experimental animals. 1. Decrease in respiratory rate. 2. Bradycardia. 3. Cardiac arrhythmias. 4. Pupillary constriction, followed by unilateral pupillary dilatation. 5. Increasing pulse pressure. 6. Increase in arterial blood pressure. Effects of increased ICP. B. Effect on cerebral blood flow. CAP, JVP, ICP. CBF equals CVR. When ICP increases, cerebral blood flow remains constant by autoregulation. The efficiency of this compensation depends on the rate of expansion of the lesion, its nature and site, and also on the compliance of the intracranial contents. CBF is increased in response to raised ICP by cerebral vasodilatation, however this causes increase in cerebral blood volume and produces further brain swelling. When maximal vasodilatation occurs, further increase in ICP causes reduction in cerebral BF. Effects of increased ICP. C. Clinical effects, symptoms and signs. Significant raised intracranial pressure can be present without symptoms or signs. 1. Headache is typically maximal in the morning and is relieved by vomiting. It is caused by distortion, stretching or invasion of pain-sensitive structures such as the bridging veins, basal and meningeal arteries. 2. Vomiting usually associates headache and typically occurs without nausea. 3. Papilledema. This is the most reliable sign of raised ICP. Its main features are papilledema. Effects of increased ICP. DI, internal brain herniation, resulting in strangulation, compression of vital structures and blood vessels. 1. Cingulate herniation, compress the internal cerebral vein in the anterior cerebral artery. 2. Central transtentorial herniation, compression of the third nerve, greater than dilated pupils. Compression of the post cerebral art, greater than hemianopia. Total blindness. Compression or ischemia of the brainstem, greater than decerebration. Coma. Distortion of the brainstem, greater than hemorrhages. 3. Uncal herniation. Compression of the midbrain, third nerve in the post cerebral art. 4. Tonsillar herniation, occurs when the cerebellar tonsils herniate through the foramen magnum, resulting in compression of medulla, decerebration, coma, cardiovascular and respiratory abnormalities, apnea. Brain herniation. 1. Cingulate herniation. 2. Central transtentorial. 3. Uncal herniation. 4. Tonsillar herniation.